Good morning, everyone. Welcome to Public Health and Minority Health Disparities Subcommittee. It is Wednesday, March 5th. We are doing an early morning subcommittee. We have 4 bills on the docket today that we didn't get to yesterday, and this will keep us on time ahead of crossover. As you all know, as we approach crossover, our schedules are going to be a little bit flexible. So thank you all for being here and being flexible. We are going to start this morning with what did I say? Erin, did I said we were
Opioid restitution fund.
we're starting with 996,
Um,
or did you want to start with 798?
yeah, can we do 798 first, just
Yes.
to have it up?
Sorry, I couldn't read my notes. So we're going to start with House Bill 798. This is the Opioid Restitution Fund Interactive Dashboard. And Erin, if you can walk us through the bill and where we are.
Sure. I sent a reprint right before subcommittee about 10 minutes ago. It is a reprint of the crossfile, Senate Bill 589, which passed Senate Finance yesterday. It has the same amendments essentially that were discussed by the subcommittee last week. So I'll walk you through the reprint just to refresh you. The bill requires the Maryland Office of Overdose Response in collaboration with MDH to develop and maintain an interactive dashboard on opioid restitution fund spending to share prescription opioid related settlement funding with the public. A county or municipality that receives settlement funds must provide MDH with specified information to include on the dashboard. So at the bill hearing, MACO had proposed some amendments which have been incorporated into the reprint. If you look on page 2 of the bill, after line 14, it provides that if there is a state, county, or municipal website that provides access to additional information on the use of opioid-related settlement funds by the state, county, or municipality, the dashboard shall include a link to the state, county, or municipality website. It also provides that the bill, this particular subsection of the bill does not apply to a county or municipality that complies with reporting requirements established in an opioid-related settlement and shares the data in the reports required under an opioid-related settlement with the appropriate state entity. It also requires the Department of Health to upload opioid-related settlement information submitted to the department by a county or municipality in compliance with the terms of an opioid-related settlement. And that is how the bill passed finance yesterday, I believe unanimously.
Thank you, Erin. And just a reminder to the members, this is the bill we heard last week. We did hold it. We heard from the bill sponsor who wanted an opportunity to speak with MACO. And my understanding is she has talked with MACO, talked with the Senate sponsor. They are all in agreement to move it as it passed finance and passed the Senate. And with that, do I have a motion on the amendments?
So move favorable.
Second.
All right, it's been moved and seconded. Any discussion on the amendments? All right, all in favor? Oh, Delegate Chisholm.
Just to clarify, so with the amendment, does that change? There was a physical note, and I thought that Sandy said they were working on that. Did that eliminate the $70,000 physical note? Physical.
It's opioid restitution funds, so it's 70,000 opioid restitution funds, which is actually under our threshold.
Okay, so they're going to take the 70,000 and use it for the contractual. I got you. Okay,
Right,
thank you.
and it will allow the counties to better track and also allow for greater transparency on how those funds are being used by the counties.
Gotcha. Thank you.
You are welcome. Thank you for the question. Any further discussion on the amendments? All in favor say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat. All right, do I have a motion on the bill as amended?
So move favorable.
Do I have a second?
Second.
All right, it's been moved and seconded. Any further discussion on the bill as amended? All right, all in favor say aye.
Aye.
Raise your hand. Anyone opposed, go ahead and raise your hand. All right, that bill passes unanimously. Thank you so much. All right, next is House Bill 996. This is Phenibut Consumer Protection Act. Last week we did just have an update as to what we were looking to do, but last week, That was yesterday. As to what we were looking to do, but we wanted a little more time. And Erin, if you can talk us through where we are with that.
So as we discussed yesterday, we're going to review the Senate bill to compare it to the Kratom bill that passed last year. It is virtually identical, of course, with the exception of the defining the different Senate versus Kratom. But in terms of the requirements for the retailers and the penalties, it is identical to the Kratom bill, with the exception that the Kratom bill also had a report. The amendments before you would strike that report requirement by the Department of Health. So the bill requires a retailer that prepares, distributes, sells, or exposes for sale a Phenibut product to disclose on the product label the factual basis on which the representation is made. A retailer is prohibited from preparing, distributing, selling, or exposing for sale a Phenibut product that does not comply with the specified disclosure, has not been recognized by the FDA as a dietary ingredient or approved drug, or that is adulterated with, contaminated with, or contains other substances. And they may also not distribute, sell, or expose for sale a Phenibut product to an individual under the age of 21. A violator is guilty of a misdemeanor and is subject to a criminal penalty. In addition, a retailer may not advertise or market a Phenibut product to minors directly or indirectly, and may not advertise a therapeutic benefit of Phenibut directly or indirectly. So the reprint that you have would strike the reporting requirement on the bill as introduced. And Delegate Bagnall, would you like me to discuss Delegate Bandari's amendment as well now, or?
Yes, please.
And Delegate Bandari has an amendment that would name the bill after J.T. Alvey, who is the young man, I believe his father testified at the bill hearing, who died, and they found Phenibut in the system when he died.
Thank you, Erin. And just to add a little context as to why we removed the reporting requirement, we had a conversation with the Department of Health. These are ingredients that are really challenging, and so we have we're going to work during the interim on more of a comprehensive legislation. But not only is it challenging to test for, it's a little bit of whack-a-mole. So we felt that it wasn't appropriate to add a reporting requirement. We would rather have a more comprehensive legislation and then do reporting out on that. With that, if I could have a motion on the amendments as described by Erin.
Move the amendment.
Second.
All right, they've been moved and seconded. Is there any discussion? All right, all in favor say aye. Anyone opposed, go ahead and raise your hand in the chat. All right, Delegate Riley.
Sorry, Madam Chair. I actually have a question before I vote. So I don't see anything on here for the Maryland retailers. Have they weighed in on this at all? Or
Yes, and that was going to be our next conversation. So thank you, Delegate Riley. So we actually, one of the reasons that we held the bill yesterday is because we wanted to reach out to the retailers because they were not in the original hearing. The retailers have made a request that we add the word knowingly in, which actually would not be the same as what we did with Kratom. We do have knowingly in other parts of the code, but we did not do that for Kratom. The Department of Health also reached out to us because, again, we shared all of this with the retailers and the department. The department would rather engage in a consumer and retailer education program rather than add knowingly to the code. So to your question, do I have anyone here from the department that wants to speak on this and or from the retailers? I see Sarah. Okay, Karen.
Yes, I can state, I think our preference for not adding knowingly would be, again, to have that education component and not create what could potentially make it difficult to enforce on this side. So we would rather have the education component and keep knowingly out of the bill.
And the department is committing to working with the retailers to make sure that we have a robust campaign.
Yes, yes, we can work on that.
Thank you. Delegate Riley.
Yes, sorry, still have a question. So in knowing that, doesn't it make it more difficult since you had mentioned earlier that this particular product is very hard to detect and to find? I think that just opens the, the businesses and the retailers up to just a huge problem in my, in my estimates until we actually break down to see what products this is actually in. Not having the word knowingly, I think it just puts them in jeopardy.
Delegate Bagnell, may I?
Yes, go ahead.
I think the argument about the department not being able to detect was about the report. Because the report is about like number of overdoses, number of times when like phenibut is found. It's not about the inability of the department to detect is separate from you're a retailer and you're actually selling the product. I mean, it's easy to see the product.
Yeah, it's on the labeling and the bill, as we passed it for kratom and as we're looking to pass it for phenibut, speaks to the labeling, the advertising restrictions on advertising, restrictions on ages that it can be sold to. So and that's why, again, why we stripped out the reporting requirement, because that had to do more with the health aspects of it. This is about the advertising and sales.
All right, thank you very much.
Absolutely. Thank you for the question. Is there anyone else who would like to be heard on this bill? We are currently on the amendments, correct? Mr. Alvey.
Thank you. If it's okay for me to speak, I'd like to just say just a couple of quick words. First of all, thank you for this bill being considered. It's really important. It's great that it's being considered in the format that it is in. I hope it's a first step. Phenibut is the drug that led to our son's death, combined with tianeptine, which was also approved last year as a regulatory step by this legislation, which was terrific. I would not change anything about the way it is now. It actually should be harsher, but there'll be research and study that could be done over the next year. We'll be back to help with that. But I just want to reinforce that this is the right thing to do now as a first step for this community, and says it in the correct way for the retailers. It matches what was done last year. Again, I think more can be done on both tianeptine and phenibut. But again, I can't thank this group enough, and Delegate Bandari for bringing this forward. So if there's any questions that I can answer, please let me know. Thank you.
Thank you very much, Mr. Alvey. And again, we are very sorry for your loss.
Thank you.
Delegate Chisholm.
Madam Chair, and I echo those sentiments to Mr. Alvey. Quick question though, where, and I'm sorry for not remembering this from the hearing, but where is this primarily purchased? I mean, is it being purchased in like gas stations or CVS, or because when we're talking about retailers, I want to have an idea of which retailers this affects and how easily they can implement it into their standard practices.
And my understanding is you're exactly right. It's primarily gas stations. It's sort of the same areas that we were seeing kratom sold. We were seeing tianeptine, and tianeptine we did take broader steps and actually had a full ban. Kratom, as you may recall from last year, the recovery community asked us not to fully ban it because they did utilize it as a non-opioid alternative in recovery, but we did put some restrictions on how it can be sold and how it can be advertised.
Okay. Thank you, Madam Chair.
You're welcome. I see Ms. Williams from the Office of the Attorney General.
Yes, I just wanted to add that I think it's not being marketed as just phenibut, it's being marketed as a dietary supplement. And so, I think for some people, they're thinking that this is something that's going to replace or help them replace their food addiction or things like that. And so it's not necessarily being promoted as an explicit drug, or people aren't quite sure what they're getting into. And so I think some of this addresses ensuring that people aren't the marketing aspect, right, from the consumer protection aspect, making sure that they understand what they are actually receiving and that it's not a dietary supplement, that it's actually an addictive drug.
Thank you very much. Thank you for that context, and I think that's really important because this is also very consistent with the FDA recommendations, which have said this is not a dietary supplement. It is not a drug. It is not, it is not to be marketed as such. And I think I'm on the amendments. We're still on the amendments. Okay, I just want to make sure. So on the amendments, all in favor, say aye. Anyone opposed to the amendments, go ahead and raise your hand. All right, on the bill as amended, do I have a motion?
So moved.
All right, do I have a second?
I'll second.
Thank you. All right, it's been moved and seconded. Any further discussion on the bill as amended? All right, all in favor, say aye. Anyone opposed, go ahead and raise your hand. Thank you very much. The bill passes unanimously out of subcommittee. Thank you, everyone, for your hard work and for this great discussion. And we are going to move on to, sorry, I got my notes out of order.
Thank you. I'll be leaving the call, and I just want to thank this group again for moving this forward. Again, it's a first step, so wonderful and honored to have JT know that something is happening good after his death. So can't thank you enough.
Thank you very much, Mr. Alvey, for being here and for your advocacy, and thank you to the bill sponsor as well for
Absolutely. Thank you.
forward.
All right. Thank you.
Thank you.
All right. Thank you. Thank you, everyone, and for the courtesy while I got back on task. All right. We are going to move to House Bill 783. This is health occupations, structural racism training. This was on our list yesterday and we just didn't get to it. So Erin, if you can talk us through the bill and the amendments.
You have a reprint of the bill, and there's also a separate amendment. So there's two documents that were sent to you on this bill. Both are amendments that have been offered by the bill sponsor, who is the chair, Payne Monick. So the bill expands the scope of required training for individuals licensed or certified by a health occupations board to include implicit bias, which is already a requirement. And then in addition to that, structural racism. Applicants for the renewal of a license or certificate issued by a health occupations board must attest to the completion of an approved implicit bias and structural racism training program the first time they renew their license or certificate after April 1st, 2026. The Cultural and Linguistic Healthcare Competency Program, in coordination with the Office of Minority Health and Health Disparities, must identify and approve implicit bias and structural racism training programs. So in the amendment that is separate, this amendment would allow health occupations boards to adopt regulations that allow an applicant seeking license renewal to receive continuing education credits for completing an implicit bias and structural racism training program. The amendments that are incorporated in the reprint alter the definition of structural racism. They allow training to be accredited by the Accreditation Council for Pharmacy Education. I will go ahead and read the definition of structural racism. It means the totality of ways in which societies foster racial discrimination by mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. The chairman would also like, and I don't have it written out yet, but the University of Maryland has a grant available and can provide the structural racism program for free. So she would like a reference to that program as a available resource, and should help with fiscal impact and the burden on the department to find a program. There is one out there.
Thank you, Erin. Do I have a motion on the amendments?
Move the amendments.
Do I have a second?
Second.
All right, we've been moved and seconded. All right, do we have discussion? I saw Delegate White Holland. I saw your hand.
Yes, I just had a question, Madam Chair, about the definition. I saw that it was updated. Is this a standard definition in which that the Maryland Department of Health uses, or stems from prior legislation that we've passed?
I think Erin has that answer.
Yeah, this was requested by the Department of Health. I believe it's the AMA definition.
Okay.
Sarah can confirm that.
Okay, thank you.
Yes, this was suggested by us, and it is a definition that we suggest because it is utilized already. It's an existing and was the one developed by the American Medical Association.
So this would be consistent with other legislation.
Yeah.
Thank you. Thank you very much, Delegate White Holland. Delegate Chisholm.
My question's along the same line. Who defines structural racism? I mean, I appreciate the AMA is weighing in, but the AMA, if we're talking about all these different factors, I don't know how the AMA can be considered a subject matter professional on this. I just think this is one of those things, again, that I think we create a bigger problem with a lot of this stuff. And I'll be voting no. I appreciate the spirit of it. We all want to be treated equally. I just don't know if this gets to it. And I think we're continuing to create more and more barriers for people wanting to enter the workforce. And, you know, some of this is just unnecessary and is not moving us forward, in my opinion. Thank you, Madam Chair.
And I appreciate your comments, Delegate Chisholm. I think we are probably going to have a philosophical difference on this one because, I think this definitely falls into the category of know better, do better. And we have, seen that we are still facing barriers to advancing population health.
Are you going to go around them or not, fucking idiot?
Thank you for muting.
Well, that was interesting.
I'm going to assume that was not related to the conversation that we're having for the sake of the body, but just our moment of levity. But this is important because we are facing barriers to advancing population health, and we have to be able to recognize those barriers. And I think that we have seen advances with our implicit bias training, which is where we're looking at ourselves, and this is looking at structural racism, which is institutional barriers to advancing population health. So with that context, are there any further questions on the amendments? All right, the amendments have been moved and seconded. We've had a discussion more robust than we were expecting. And all in favor of the amendments, say aye.
Aye.
Anyone opposed to the amendments, go ahead and raise your hand. All right, on the bill as amended, do we have a motion?
So
The bill is amended.
Second.
All right, thank you. It's been moved and seconded. Any further discussion on the bill as amended? All right, seeing none, on the bill as amended, all in favor say aye.
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 Anyone opposed, go ahead and raise your hand in the chat. All right, we've got Chisholm, Riley, Hutchinson. The bill passes not unanimously. Thank you all very much. We have one more bill to go, and we're doing well on time. So thank you all for your hard work this morning. And we are going to House Bill 737. This is the non-opioid advance directive.
Back, no, I think you froze.
Spoiler alert, this is my bill, but we have been working with. Oh, am I back?
You're back.
Okay, thank you, everyone.
You ended on, I believe this is my bill.
Yeah. So I just said, oh, that's embarrassing. That I said that it is my bill, but we have been working with all of the stakeholders to address the concerns that were raised during the bill hearing. And so, Aaron, if you could talk us through the bill, the proposed amendments, and then I'll also give a little context to the broader conversation that we're going to be having that was started by this bill.
So the bill as introduced authorizes a competent individual to make a non-opioid advance directive, stating that the individual refuses the offer or administration of any opioid medication, including during an emergency where they cannot communicate their preference. And the bill would have required the Department of Health to develop a model non-opioid advance directive form, publish it on MDH's website, and adopt regulations. There is a reprint that has been provided. That reprint would strike the bill as introduced. And it looks like a lot of new language, but it's not. Currently in the Health General article, there is a model advance directive form. And so that is what you see in the reprint. And that's what this bill does now is adds the issue related to opioids and your preference not to be given opioids in this model form. So if you, unfortunately, there aren't marked page numbers. So I'll count. So bill page 2.
I think it's page 9.
4, 5. Yeah, sorry, I should have marked it. So that there's, if you flip through and look for bold small caps, that is where there is new language. So currently there is a provision in the model advance directive form related to pain relief. And the bill would amend that portion to provide that a person could initial that I understand that in case of emergency, when there is a substantial risk of death or imminent and serious harm and delay in treatment to obtain consent would adversely affect my health, healthcare providers may administer opioid medications in accordance with the Health General article. And so you could check that option. Or you could say, no matter what my condition, give me the medicine or other treatment I need to relieve pain. Or unless medically necessary, I do not wish to be offered or administered any opioid medication. And then there's one more provision, and that's to the second to last page in the bill. And that provides that a healthcare provider is not subject to criminal prosecution or civil liability or deemed to have engaged in unprofessional conduct as determined by the appropriate licensing authority as a result of administering an opioid medication when the administration is medically necessary.
Thank you, Aaron. And I'll open it up for discussion in one moment. I just also wanted to add that we worked with the opponents of the bill. We took the language from MedChi, the medically necessary, but also in working with some of the opponents, particularly with Hospice of the Chesapeake and some of the other hospice care folks, we learned that their concern was actually with the advanced directives writ large. So we will be creating a work group during the interim to look at our advanced directives because it has been a while since we actually took a deep dive on our Advanced Directive Act. With that, let me open it up for discussion. Delegate Hutchinson.
Thank you, Madam Chair. You sort of addressed my question because I have been following the concerns of MedChi and the hospices, and that has created concern with me about this bill. I would like to hear directly from MedChi and the hospice if they're online about their views of the amendments and where we stand with the bill now.
Do we have?
Ms. Kaufman's on the line.
There we go. We've got Dana Kaufman. We've also got Dr. Jordan. So Ms. Kaufman.
I have to be honest, I have not seen the amendments. I'm not principal on this bill, but I will take a look. They sound like they would address our concerns since you did include medically necessary.
And we took the language directly from MedChi, and unfortunately we have been reaching out, but I think it's that time of the session where this one wasn't top of mind for everyone. And I see Dr. Jordan and Peggy Funk. Go ahead, Dr. Jordan.
Good morning. So number one, thank you for the amendments. I see that there have been numerous amendments. Peggy Funk, we're a part of the Hospice and Palliative Network of Maryland, so she'll speak to, their position. I can tell you from Hospice of the Chesapeake, we've taken a look at it, and again, we appreciate the amendments, but where we've landed is there is a section in there where it says the offering of opioid offering or administration. And so some of our physicians sort of feel like, or in advanced practice providers feel like that kind of goes against our Hippocratic oath. If we see a patient suffering, to not offer is sort of counterintuitive to everything that we do as medical providers. If we see an issue, we discuss the appropriate modalities for the management of that condition. So the word offer caused a little bit of hesitancy with us. And then I'll let Peggy Funk discuss more about our position from the Hospice and Palliative Network. But we do wholeheartedly appreciate all the amendments and adjustments to the bill.
Yeah. Thank you, Rachel. And good morning, everyone. Thank you. I appreciate this opportunity to weigh in a little bit more in depth on this. My name again is Peggy Funk, and I represent the Hospice and Palliative Care Network of Maryland. So just to weigh in, really to let you all know, our members just met as recently as Monday to discuss this. And I want to say it's really our medical directors who have a concern about this legislation. There actually seem to be just 4 or 5 reasons that this has come up. First off, they're very concerned about using this advance directive as a mechanism, if you will, to treat an opioid addiction. So they just don't think this is the place to be doing that. Secondly, they feel like this is going to really confuse language, especially for people who have a low literacy level. It's already confusing. We have enough trouble trying to get people to sign on to an advance directive with just not adding more layers to it, if you will. And also, they really have an issue with the term medically necessary. They feel like that's even more confusing. And then lastly, hospice and palliative care, a lot of our quality measures are based on pain control. And if we start adding this kind of language to the advance directive, it's going to make it just that much more difficult for, we feel, our members to be able to do their job. So while we are very appreciative of this amendment, and the collaboration and working on this bill has been fantastic, we appreciate that. I will say we are also grateful for the work group that is looking to be formed during the interim. So just wanted to share with you our thoughts on this legislation.
And I appreciate that, and I thank you for collaborating with us. I do want to say that the reason that we were forming the work group was to address some of those overarching concerns, which don't necessarily speak to this specific bill, but the concerns around advanced directives, all encompassing, and I think they are more than reasonable to consider.
Thank you.
And I don't think I've asked for a motion on the amendments. Is that correct? Do I have a motion on the amendments for this bill? Are we still wrestling with it? Do I have questions from the members? As I can see, you're all wrestling with it. So let's go ahead and have the conversation so we can get our questions answered. Go ahead, Delegate Rosenberg.
Is there time to have more discussion with the docs on this? Because it would seem odd for us to be moving forward with a bill which is on this issue where, I mean, this isn't a, who's going to be licensed issue. This is a
No, I
provision.
I appreciate
I'm
that.
not
That's why I
saying
want to
being
have that
critical of
discussion
you.
now. Yeah.
Yeah.
So Mr. Fiastro, go ahead.
Delegate, Madam Chair, thank you very much for the time this morning. My name is John Fiastro. I represent Haleon. And I do want to bring to, I did testify at the hearing. So this is the second time you're hearing me on this bill. I did want to give the members of the subcommittee some background in terms of how much discussion has taken place during the interim on this bill. Initial conversations started in May and June with the AG's office because the AG is the holder of the state's advanced directive, the boilerplate advanced directive adopted in 5603 of the Health General article. Subsequent conversations took place with the Maryland Bar Association, MedChi, the hospice folks. These conversations took place, MHA as well. These conversations took place over the course of the fall and into December before session. So I want to make sure that subcommittee members do understand that this is not, this bill before us as contemplated conceptually has been socialized well over the course of the interim. So while you might be hearing some concerns, I believe that the delegates' amendments that she's bringing forward addresses them. Those concerns boil down to three pieces. First, it's too confusing a first reading version of the bill to have a third advanced directive in statute. That concern is answered by folding it into the existing advanced directive that was adopted in 1993 and has been statute since. The second one is the concern about flexibility to properly administer. And that one, that amendment we've discussed has been treated with the medically necessary language and providing some outlets for practitioners to be able to proceed with the course of treatment that they intend, that they believe is in the best interest of the patient. And then lastly, liability concerns, which are already afforded practitioners within the 5609 of the Health General article. These are all, well thought out and well contemplated amendments. They are in response, and I did want to make mention of that. I think some of the concerns that you're hearing are generally overall concerns about the framework of the Health Decisions Act. And like I said, that original statute was adopted in 1993, has been precious treatment of that since, precious little treatment of that since. And so, I thank the chair of the committee and the subcommittee chair to committing to working on the work group to examine these overarching issues. But I think this is a very precise treatment. It allows for patients to have a say in the treatment that they're receiving. And with that, I'm here to answer any questions because I've been working on this for 10 months. So if you have any questions, I'm here to answer them. Thank you, Delegate.
Thank you very much, Mr. Fiastro. And just to, again, spoiler alert, I'm going to hold this bill, but I do want to go ahead and have the discussion so that we can get all the questions out that we need answers for, because we have time. We don't need to rush. Let me go to Delegate Hutchinson and then Ms. Kaufman.
Actually, Madam Chair, I would like to hear what Ms. Kaufman has to say because I still have grave concerns around MedChi's concerns and the hospice concerns. So I'd be interested to see what she has to say.
Okay, go ahead, Ms. Kaufman.
Thank you very much. And it's my understanding now, listening to the conversation, that these are brand new amendments, even though they've been discussed, but these amendments haven't been circulated. Would it be possible to circulate the reprint? Because I think that would give us a better understanding of what is being discussed, and then we can more fully weigh in. That was my understanding.
Erin, can we?
No, so usually with the amendments, I just send them to the members.
Okay.
And then I am more than happy. I will get all the people who are here on this call about this bill a copy of the amendments.
I think that would be appropriate because we do have some concerns, and I think the amendments out of context of the overall advanced directive may actually be more confusing than just seeing them in context. So are there other questions from the members? Don't worry, there's no pressure from me. We have time. But I want to make sure that we're getting all of our questions down so that we can get answers going forward. Delegate Hutchinson, you still have your hand up.
Oh, yeah, I'm sorry, Madam Chair, I do.
No, you're good.
I think it would be appropriate to hold the bill. I think there's still some unknowns right now.
Agreed. So what we're going to do is we're going to hold this bill. We are going to circulate the amendments, the reprint, because then we'll be able to see the amendments in the context of the overall advanced directive. And then we will revisit this bill after we've had an opportunity for the stakeholders who still have outstanding concerns. Does that sound reasonable to everyone? All right, perfect. Well, that does complete our work for today. And with that, I'm going to give you back 30 minutes of your morning. Thank you all so much for getting up bright and early and doing the work. And I will see you all on the floor.